One topic from respiratory system that is remaining is pleural effusion, the important topic. There is a long case in practical also and a long question in theory also. So pleural effusion, very important topic. So what is pleural effusion? Pleural effusion is nothing but it is the collection of abnormal amount of fluid in the pleural space. Pleural space is nothing but it is the space around your lung. Your lung having two coverings, two layers of pleura around the lung, visceral pleura and parietal pleura. So in between visceral pleura and parietal pleura, there is a pleural space. So in that pleural space, the abnormal collection of fluid is called pleural effusion. So this abnormal collection of fluid, it can be water, it can be pus, it can be blood, it can be chyle, anything. So pleural effusion is nothing but a collection of abnormal amount of fluid in the pleural space. So pleural effusion, a collection of fluid in the pleural space, is rarely a primary disease process. Means pleural effusion always having underlying cause. It is not a disease, just like anemia. Anemia is not a disease. It is a sign of underlying disease. So just like that, pleural effusion is not a separate disease. It has underlying cause. Just like heart failure. Heart failure is not disease. It is a sequelae. It has underlying cause. So just like that, pleural effusion has underlying cause. So it is not a primary disease process, but it is usually secondary to other diseases. You have to search out, you have to find out the cause of pleural effusion. So pleural effusion is the collection of abnormal amount of fluid in the pleural space, always having underlying disease. You have to find out the cause of pleural effusion. So it is not a primary disease process, but it is usually secondary to other diseases. The pleural space normally contains only about 10 to 20 ml of serous fluid. So pleural fluid, normally it sits continually into the pleural space. Normally there is fluid, but only 10 to 20 ml. So normally the pleural fluid sits continually into pleural space from the capillaries. So this fluid comes from capillaries, which are lining the parietal pleura, and is reabsorbed by the visceral pleura or visceral pleural capillaries. So fluid comes from capillaries, which are lining the parietal pleura, and it is reabsorbed by the visceral pleural capillaries and the lymphatic system. So any condition that interfere with either the secretion, means production, or the drainage, means removal of the fluid, that lead to pleural effusion. So either there is excessive secretion, or either there is problem with the drainage or problem with the removal. So anything which disturb the balance of secretion and drainage, anything which disturb the balance of secretion and drainage leads to pleural effusion. So any condition that interfere with either the secretion, means either increased secretion, or drainage, means removal of this fluid lead to pleural effusion. So pleural effusion, it is of two types, transudative type and exudative type. Transudative type of effusion means the collection which is occurring having the same composition as that of plasma. Then that is called as transudative effusion. Anywhere in the body, whenever there is abnormal collection of the fluid, if the composition of that fluid is same as that of your plasma, the composition is same as that of your plasma, then it is transudative type of effusion. And exudative effusion means it is always secondary to some inflammatory process. Exudative effusion is always secondary to some inflammatory process, and it has a different composition than that of plasma. So transudative effusion, also known as heterothorax. So pleural effusion, also called heterothorax or heterothoracis, occur primarily in non-inflammatory condition. So it is usually non-inflammatory. Transudative effusion is non-inflammatory, and it is an accumulation of low protein and low cell count fluid. So it is non-inflammatory. Exudative is always secondary to inflammation. Transudative is non-inflammatory. Cause of transudative effusion. So there are different mechanisms for transudative type of effusion. One is increase in hydrostatic pressure. Increase in hydrostatic pressure. If the hydrostatic pressure in the capillaries in the blood vessels increase, then that results in the fluid coming from the muscular compartment into interstitial spaces. Increase in hydrostatic pressure in the vascular compartment results in exudation of fluid from the muscular compartment, means from intravascular compartment to the interstitial spaces. So that results in pleural effusion, just like the mechanism of edema in heart failure. The mechanism of edema in heart failure, the mechanism of pulmonary edema, the mechanism of systemic congestion, the mechanism of pulmonary congestion in heart failure is related to the increase in hydrostatic pressure. So just like that, whenever there is increase in hydrostatic pressure in any condition like renal failure, heart failure, liver cirrhosis, then in that case, because of increase in hydrostatic pressure in the capillaries which are lining the pleura, increase hydrostatic pressure in the capillaries which are lining the pleura results in pleural effusion. So pleural effusion or transmitted type of pleural effusion is and the underlying most common cause is heart failure. The underlying most common cause is heart failure. So one of the mechanisms is increase in hydrostatic pressure, just as we discussed in heart failure. So it's the most common cause of pleural effusion. Second mechanism is decrease oncotic pressure. Oncotic pressure means this pressure is related with the proteins, the level of proteins. Oncotic pressure is because of presence of proteins. So decrease oncotic pressure. So decrease oncotic pressure occurs when there is hypoproteinemia, decreased protein level in the body, also called as hypoalbuminemia, decreased albumin level. So hypoproteinemia causing decreased oncotic pressure, that which is commonly seen in liver cirrhosis or nutritional problem. Hypoproteinemia is either nutritional or because of loss, either poor intake or because of loss. So loss of protein occurring in nephrotic syndrome, these are renal diseases. So hypoproteinemia, the causes, one is nutritional, second in liver cirrhosis, and third renal diseases. Most common in nephrotic syndrome, where there is proteinuria. So decrease oncotic pressure, also called as hypoproteinemia or hypoalbuminemia, results in transulative type of pleural effusion. The causes are liver cirrhosis, renal diseases, and nutrition, where there is decreased oncotic pressure. So in this condition, fluid movement is facilitated out of the capillaries into the pleural space. So the mechanism for transulative type of effusion is increased hydrostatic pressure, decreased oncotic pressure. And the causes are heart failure, liver cirrhosis, and renal disease. Next, exudative type of diffusion. Exudative type of diffusion is always inflammatory. Transudative is non-inflammatory. Exudative is inflammatory, means there is inflammation of the pleural layers, inflammation of the pleura. There is inflammation of pleura. So it occurs in an area of inflammation. It is an accumulation of high protein fluid. It is accumulation of high protein fluid. Transudative type of fluid is low protein fluid. So an exudative effusion, it results from increased capillary permeability. There are two mechanisms. One is inflammation, which results in increased secretion. The inflammation of the pleural membrane, inflammation of the pleura, that is called as pleuritis. Inflammation of pleura is called pleuritis. Can be acute, can be chronic. Can be because of secondary to autoimmune diseases, can be secondary to malignancy. So pleuritis is inflammation of the pleura which occur as a result of acute infection, chronic infection, because of autoimmune diseases, and in malignancy. So the inflammation of pleura results in increased secretion of the pleural fluid, means the balance of secretion and reabsorption decreases, or it is disturbed. Increased secretion as compared to reabsorption. So that results in excess amount of fluid to accumulate in the pleural space, and that is exudative type of diffusion. So one mechanism is inflammation of the pleura. Second mechanism is increased capillary permeability, means damage to the capillary wall. There is damage to capillary wall, increased capillary permeability as a result of inflammatory reaction. As a result of inflammatory reaction, that also results in exudation of the fluid from the capillaries into the pleural space. So this type of effusion occurs secondary to conditions such as malignancies, infection, and embolization. So most commonly, exudative type of effusion is secondary to infection, either acute or chronic. And second most common cause is malignancy. And third is autoimmune diseases. So pathophysiology for transulative type of pleural effusion, as we discussed, increased hydrostatic pressure and decreased oncotic pressure. That results in the fluid coming from intravascular space into the interstitial spaces, and that results in effusion. Executive type of diffusion, invasion of microbes means as a result of infection, either acute or chronic infection. These microbes or the bacteria, they initiate the inflammatory reaction. This inflammatory reaction causes vasodilatation and increased capillary permeability. Then leaking of the plasma protein that results in further decrease in oncotic pressure and the fluid shift between the interstitial spaces. So increased capillary permeability, increased secretion, loss of proteins, decrease oncotic pressure, all this results in exudative hypertension. So it is always an inflammatory process. Exudative hypertension occurs in inflammatory process or inflammation of pleura. So see, this is your lung, this is the rib cage. Inside the rib cage there is parietal pleura, and around the lung there is visceral pleura. So in between this visceral pleura and parietal pleura, it is the pleural space all around the lung. It is the pleural space all around the lung. So collection of fluid in this pleural space. See the collection of fluid in this pleural space around the lung. It is pleural effusion. It is pleural effusion. It is always a secondary process. So etiology for transroute type of diffusion and etiology for exroute type of diffusion. So first etiology for transroute type of diffusion. Transroute diffusion arises from more commonly as we discussed CCF, congestive heart failure, congestive cardiac failure, liver cirrhosis, nephrotic syndrome, and hypoproteinemia. Exroute type of diffusion, most common cause is tuberculosis in our India. Most common cause is tuberculosis in chronic infection. In acute infection, it is secondary to pneumonia, secondary to lung abscess, bacterial fungal pneumonia, empyema. Empyema means collection of pus in the pleural cavity. Empyema is collection of pus in the pleural cavity, that is called empyema. Subphrenic abscess means most commonly below the diaphragm. Subphrenic abscess means below the diaphragm. Hepatic abscess, subphrenic abscess, that can also result in right-sided pleural effusion. So exudative type of effusion, most common cause is pneumonia, second tuberculosis. Most common pneumonia, and then tuberculosis, and then liver abscess, subphrenic abscess, pancreatitis. These are the most common causes. And then the next most common cause is malignancies, either primary lung malignancy or secondary metastasis. So executive type of effusion, most common cause infection. Acute infection include pneumonia, lung abscess, or liver abscess, subphrenic abscess. Chronic infection include tuberculosis, then pancreatitis. So this is infective causes. Then second next most common cause for exudative effusion is malignancy, either primary lung cancer or secondary metastasis. And third most common cause is autoimmune diseases. The most common is SLE, that is systemic lupus erythematosus, and rheumatoid arthritis. Rheumatoid arthritis and SLE, that is autoimmune disease. These are the causes of exudative type of effusion. See, cancer, embolism, SLE, rheumatoid arthritis, intra-abdominal abscess, and then esophageal perforation. These are the causes for exudative type of pleural effusion. Now the clinical feature of the patient's presentation. What are the patient's complaint with pleural effusion? Whenever there is fluid in the pleural space around the lung, what is the patient's presentation, or with which complaint patient comes to you? With which complaint patient comes to you? So first, the symptoms are related with the underlying cause. The patient presentation or the patient's complaint or the patient's symptoms related with the underlying cause of pleural effusion. So what is the underlying cause of pleural effusion? Whether pneumonia is causing pleural effusion, tuberculosis is causing pleural effusion, cancer is causing pleural effusion, or autoimmune disease causing pleural effusion. So symptoms related with the underlying cause. If it is pneumonia, because of secondary to pneumonia, the patient initially having fever, cough, breathlessness. If it is because of tuberculosis, patient always complaining of low-grade fever, anorexia, weight loss, fatigue, etc. And so, if it is because of malignancy, again patient's complaints are anorexia, weight loss, then fatigue, anemia, like that. These symptoms related to the underlying cause. Whether it is pneumonia, whether it is tuberculosis, whether it is cancer, whether it is autoimmune disease. So patient presentation depending on the underlying cause of pleural effusion. Now the symptoms directly because of pleural effusion. Symptoms because of pleural effusion means collection of fluid. What causes? The mild collection of fluid will not cause any symptom. Mild collection of fluid will not cause any symptoms. Symptoms are only because of primary disease. But if effusion is moderate to large, if effusion is moderate to large, causing compression of your lung. If effusion is moderate, there is moderate collection or large collection, then it will compress your lung. Or if it will compress your lung, patient complaining of breathlessness. When it compressing your lung, patient complaining of breathlessness. So the patient chief complaint is breathlessness or dyspnea. If when pleural effusion is moderate to large, so mild pleural effusion will not cause breathlessness. Moderate to large effusion cause breathlessness because of compression of underlying lung. Second most common complaint is pleuritic chest pain. Means there is a chest pain on the affected side. Whether pleural effusion is on the right side or whether it is on the left side. If effusion occurs on right side, patient complaining of chest pain on right side. If effusion occurs in the left pleural space, patient complaining of chest pain on the left side. So chest pain, breathlessness, and non-productive cough. These are the chief complaints associated with direct to the pleural effusion. So pleuritic chest pain, breathlessness, and non-productive cough. These are the three main complaints of patient with pleural effusion. So this chest pain is usually very sharp. So how to differentiate this chest pain? This chest pain is very sharp. It is exacerbated by movement of the pleural space. Means the pain increase with deep inspiration. Patient cannot take deep breaths. So this chest pain aggravate with deep inspiration, coughing and sneezing. So this pain is very sharp and it increases or aggravate or exacerbated with deep inspiration, coughing and sneezing. So that is the clinical manifestation in patient with pleural effusion. Chest pain, dyspnea, non-productive cough and symptom related with the underlying cause. So usually the clinical manifestations are those caused by the underlying disease and the severity of the effusion. So pneumonia causing fever, chills, and pleuritic chest pain, cough, breathlessness. Malignant effusion again results in dyspnea, coughing, anorexia, weight loss. So like that. Now the patient's examination, general examination and systemic examination. Systemic examination means examination of the respiratory system. So what are the positive findings on general examination, positive findings on systemic? So on general examination, what you get? The signs again related with the underlying cause. Signs again related with the underlying cause. So if the underlying cause is infective cause, if underlying cause is infective cause, then patient can be febrile. Increase respiratory rate, no doubt, because patient is breathless. There can be pallor if the cause is malignancy or the cause is tuberculosis. Pulse rate can be increased because of fever. Then edema is present if the cause is because of heart failure, renal disease, or liver cirrhosis. Means if it is transitory type, it is non-inflammatory. If pleural effusion is secondary to heart failure, secondary to liver cirrhosis, secondary to hypoproteinemia, secondary to renal disease, then along with pleural effusion you get edema also. So edema can be present depending on the cause. So pallor can be present if it is tuberculosis or malignancy. Edema can be present if it is because of secondary to heart failure or liver cirrhosis. Clubbing can be present if it is secondary to malignancy. So all these findings on general examination depending on the underlying cause. Clubbing is most commonly CLM. Most commonly CLM. If the underlying cause is CLM, then clubbing can be present. So on general examination, patient can be febrile, respiratory rate is increased because patient is breathless, pallor can be present, pulse rate is increased, edema can be present, clubbing can be present, all depending on the underlying cause. In case of respiratory system, inspection, palpation, percussion, and auscultation. These are the 4 points. So in inspection, you can see that the chest movement on the affected side are decreased. If the pleural effusion is on right side, the chest movement on the right side decreases. If it is on left side, the chest movement on left side decreases. When you ask the patient to take deep breaths, When you ask the patient to take deep breaths, your chest expand well. Your chest should expand well. But if there is pleural effusion, if there is pleuritic chest pain, patient automatically restrict the movement because of pain. Because the chest movement aggravate the pain. So patient automatically restrict the movement. That means there is decreased chest movement on the affected side. When patient try to take deep breaths, chest movement on the affected side decrease. Even on palpation, you can confirm that the chest movement are decreased on the affected side. Then in palpation, next we have to see the position of trachea, whether trachea is central or trachea is deviated. Normally, your trachea is in central position. But if your diffusion is very large or cross, the trachea can be shifted to opposite side. Your trachea is pushed to opposite side. If there is a pleural effusion, large pleural effusion on right side, trachea is pushed to left side. If there is a large pleural effusion on left side, trachea is pushed to right side. So there is tracheal deviation on the opposite side in case of massive effusion. So you have to confirm the position of trachea. So all these points you have to learn in practical actually. In theory it is not possible to teach. So all these are the points actually in practical. So we will discuss in practical also later on. So tracheal deviation on opposite side in case of massive effusion. Stony dull on percussion. So normal lung area is resonant when you percuss or when you tap the area of the lung. Because your lung contains air, so normally you get resonant sound. Your lung contains air, so normally you get resonant sound. But now there is a collection of fluid around the lung. There is collection of fluid around the lung, and fluid is a bad conductor. Fluid is a bad conductor of the sound. So whenever there is collection of fluid, either it is blood, either it is pus, either it is fluid, anything. So whenever there is any collection around the lung, that results in stony dull note on percussion. That results in stony dull note on percussion. What is stony dull note? If you percuss over the bone, if you percuss or tap over the bone, so that note is stony dull note. That note is stony dull note. If you tap or percuss over the soft tissue like muscle, that note is dull note. That note is dull note. So normally when you tap or percuss over the chest, in the field of lung, as the lung contains air, you get resonant sound. Normally you get resonant sound. So stony dull, these are the abnormal notes. So in case of pleural effusion, you get stony dull because fluid is a bad conductor. So positive finding in inspection, decreased chest movement on the affected side. In palpation, you can confirm that there is decreased chest movement on the affected side. There is local tenderness on palpation. Then the position of trachea deviated to opposite side. In case of percussion, there is stony dull note. And now the auscultation. You have to auscultate the area of the lung with the help of stethoscope. When you keep the stethoscope over the chest, if there is a pleural effusion on right side, if you auscultate the area on right side, you get the absent or decreased air entry on the right side. So there is no air entry or no breath sounds. So you cannot hear any air entry or you cannot hear any breath sound in that area or on the affected side. So that is absent or decreased air entry on the affected side. So if there is a right-sided pleural effusion, air entry absent on right side. If there is a left-sided pleural effusion, absent air entry on left side. So in auscultation, there is absent or decreased air entry on the filter side. So these are the findings in case of respiratory system. Positive finding, decreased chest movement, local tenderness, tracheal deviation, stony dull note, and absent air entry or decreased air entry on the filter. So these are the positive findings in case of a pleural effusion. So in practical, you have to explain your positive finding on general examination and in system examination that support your diagnosis. So your finding, your history should support your diagnosis, and you should be able to explain why you give this diagnosis to the patient. So from history point, from examination point, you have to support your diagnosis, and you should be able to explain your diagnosis. Why you are putting the diagnosis of pleural effusion. So the positive finding on examination, on general and system examination, from history, you have to support your diagnosis that it could be a pleural effusion case. Now, in case of per abdomen, If it is because of heart failure or it is transient type of effusion, you get presence of ascites, palpable liver, etc. Or if it is because of secondary to liver cirrhosis, you get the presence of ascites. Ascites means it is the collection of fluid in the peritoneal cavity. Just like collection of fluid in pleural space. Collection of fluid in pleural space is pleural effusion. So collection of fluid in peritoneal cavity is ascites. So in parabdomen, if it is transient or depending on the underlying cause, there is presence of ascites. In case of cardiovascular system, if the pleural effusion is secondary to CCM, secondary to heart failure, then you get gallop rhythm, which is the characteristic of CCM. Gallop rhythm is presence of extra heart sound, S1, S2, S3. That is called as gallop rhythm. Normally there is S1, S2, but if you get additional heart sound, that is S3, then it is called gallop rhythm. So presence of gallop rhythm, if the cause is CCM. Investigations in case of a pleural effusion, most common pleural effusion can be diagnosed from X-ray chest. Pleural can be diagnosed from X-ray chest. So from X-ray chest, at least you understand that there is a collection of fluid or there is pleural effusion. So at least you able to understand that it's a case of pleural effusion. And then further investigations to find out the cause of pleural effusion. So first you have to confirm that there is pleural collection. First you have to confirm that there is pleural collection or there is pleural effusion. And to confirm this collection, there are two important investigations. One is X-ray chest and second is ultrasound. Ultrasound of the thorax. So from X-ray and from ultrasound. And CT is rarely required for the diagnosis of pleural. So UHG and X-ray, these are the diagnostic. You can diagnose at least that there is a presence of fluid in the pleural space. So CT is homogeneous opacity on the left side of the chest. So this is right lung, this is left lung, this is the cardiac shadow. So right side of the lung field is clear. On left side there is homogeneous opacity. See, this is homogeneous opacity, middle lobe, lower lobe, complete opacity. So it is nothing but the collection of fluid. It is a collection of fluid which is giving this opacity. See, left lung field is clear. Now this is right lung field, complete opacity. Right lung field there is complete opacity. It is a gross pleural effusion on right side. It is a gross pleural effusion on right side. And see, this is the tracheal air column. This trachea is shifted to left side. The trachea is not central position. Trachea is shifted to left side. So it is right-sided pleural effusion. This is left-sided pleural effusion. So from X-ray you can diagnose the presence of pleural effusion. If in X-ray there is doubt about pleural effusion, you can do ultrasound. So from ultrasound also you can confirm that there is abnormal collection of fluid in the pleural space. Once you diagnose that it is a case of pleural effusion, your aim is further to decide the cause of pleural effusion, to decide the underlying cause of pleural effusion. So we will discuss the remaining part